mitral stenosis. You know, the aim of the paper is to, the aim of the question papers is to make sure you can deal particularly with the common and important things. They don't come much more common and important than the aortic stenosis. So make sure you know that, even though it's part of your normal everyday workload. Okay. When I arrived here in Stoke, or when I came to look at the job in Stoke after they advertised it as a consultant, and I came to visit on it, and I came on a Friday because the Echo meeting was on a Friday, not because, but it happened, the Echo meeting was on a Friday. And I went to the Echo meeting, and there's always really smart, experienced people sitting around discussing, you know, this patient and how bad we thought their mitral regurgitation was. An Echo meeting here still happens on a Friday. I missed it today. Still happens on a Friday. And if you walked in today, there's a high chance that all these people, some of them still the same people, would be sitting around discussing how bad somebody's mitral regurgitation was. I think the assessment of regurgitant lesions is really hard, particularly in mitral regurgitation. So along with the assessment of left ventricular function, I think this is really tricky. Okay. Aortic regurgitation, first of all. So the aortic valve is different from the mitral valve. The aortic valve works just because it's beautiful geometry. There's a pipe, the aorta, it comes down, it swells out at the end, it turns in itself, the leaflets lie on each other and they seal perfectly, just from their shape and the fact that along the tips of the leaflet it's a sort of reinforced structure, and then where they all three meet in the middle is a little dimple that seals a dimple. It is, I'm not a romantic chap, but it is beautiful. Yep. Really cleverly designed. It depends only on its shape. It's held in place because the high pressure here forces the cusps against each other. High pressure from above in the aorta. It's really clever. But the downside of that is that any disruption to the shape of the leaflets or the thing that the leaflets are hung on, the aortic root, will stop the valve from working well. It won't be able to seal and it will leak. So you can have aortic regurgitation either because the valve leaflets aren't same shape as they should and mobility as they should be, or because the aorta has changed, even though the valve leaflets haven't. So primary AR, problem with valve leaflets, secondary problem with the, problem with the aorta. Okay, so you've got problem with valve leaflets. They can just be degenerative, it can be rheumatic. We've seen an example of rheumatic valve already, it can be endocarditis or a number of other things. The secondary, it happens because of something going wrong with the aorta, such as this, you know, huge aortic dissection that you can see here. This is the true aorta here. This is the rip, and this big, huge lump thing is the false lumen that shouldn't be there. And that, of course, will completely disrupt the aorta and therefore change the shape of the aorta and therefore change the ability of the leaflets to close. So lots of things can cause that. So when you're describing the aortic valve, it's really important that you don't just describe the aortic valve, but you also describe the aortic root, because that's the structure that holds the aortic valve in place, and without that, it won't work. So you know all this, where to measure and how to measure. So that's the first part. You look at the valve, you identify it's leaking, you identify why it's leaking. Is it the aorta or is it the valve leaflets? And once you've done that, you then need to identify how bad the leak is. And there are a number of things that you can use to identify that. The width of the jet, you can look at the continuous wave of the regurgitant flow. We didn't say this morning, but you know that Doppler flow comes from scattering. It's a low energy signal. It just tells you about the speed, but if you go and get scattering from one red blood cell, you're going to get a very quiet signal. If you've got 10,000 red blood cells all moving at that speed, there's going to be a lot more scattering at that speed, so you get a lot stronger signal. So the volume of the signal, which is the intensity of the signal in a picture, so how bright the curve is in CW, tells you something about the volume. It's a semi-constant measure of the volume of the blood. So you can look at the density of the CW Doppler, look at the pressure half time, or if you use my aortic valve here, and the heart squeezes, blood comes out, and then some of it will fall back in if we've got aortic regurgitation. If I've got a small hole, then the volume that goes through a small hole is small, and that volume comes just from my proximal aorta just sort of collapsing a little bit in a way you don't notice. I've got a big hole in my aortic valve. Now, a big volume of blood is going to fall back into the left ventricle. And that can't just come from the proximal aorta, because we know it doesn't really collapse much. It has to come from the arch and from the descending aorta and come all the way back round. So in severe aortic regurgitation, what you see is you see blood going forwards around the aorta and then coming back, and then going forwards and then coming back. And the further round that you can see this forwards backwards business, the bigger the leak. So if you can see aortic flow reversal in the descending aorta, then that's a really bad thing. So you need to look at the width of the jet. You can look at the short axis to see the area of the jet. You can look at the narrowest point of the jet, which is called the vena contracta. You can measure how wide the jet is using color Doppler, between here and here. So between the end of the T wave and the next QRS complex, that's diastole. And during diastole, there should be nothing and no movement in the left ventricular outflow tract. That should only happen during systole. But you can see here the left ventricular outflow tract is absolutely full of color, so that you've got the whole of the left ventricular outflow tract full of color during diastole. That means a very wide jet. So use the color M mode to assess the importance of the jet. So it said that you can put the suprasternal notch, look down the descending aorta, and look and see if you see, as you do here, forward flow, then backward flow, then forward flow, then backward flow. And the more of that you see in descending aorta, the more severe the aortic regurgitation. You look at the density and the slope of the continuous wave. You can use PISA in the exam. I'm sure you won't be asked to use PISA for aortic regurgitation. And then you can put it all together. And these are the numbers that are produced by the BSc. I'm sure the regurgitant fraction, regurgitant orifice area, regurgitant volumes, if you would be asked any of those, you'd be asked those in the exam in the context of mitral regurgitation. But even then, I don't think you'd be asked about regurgitant volumes. I think you'd be asked about regurgitant orifice areas. So I think what you might need to do in numbers, because it might give you numbers. I don't think you'd be asked to calculate these things for aortic regurgitation in the exam. But the other numbers you definitely need to know. Relatively common valve lesion, but not as important as aortic regurgitation. Mitral regurgitation, I think, again, is something there's a very high chance you've got a question on, either a video case or in the MCQ paper, because it's so common. The mitral valve is different from the aortic valve. It doesn't just work because of its geometry. It works because of those. It works because of those chordae, those strings that we talked about this morning, that go tight and hold the valve leaflet there, and they go tight, connected to the papillary muscle, connected to the muscle. Yep. So if anything goes wrong with that chain, then the leaflet will be free to move to the wrong position, and it won't seal properly. So a problem with either the chordae, if the chordae snap, or with the papillary muscle, if that infarcts, or with the myocardium that the pupillary muscle is attached to. If that infarcts, any of those things will cause mitral regurgitation. So unlike the aortic valve, which only would stop sealing if something went wrong with the leaflets or something went wrong with the mounting frame, i.e. the aortic root, nothing else will make you have aortic regurgitation. That's not true here. Something goes wrong with the leaflets, you'll have aortic regurgitation. Something goes wrong with the mounting frame, that is the mitral valve annulus, you'll have mitral regurgitation. But also, if something goes wrong with the myocardium, you'll have mitral regurgitation. So suddenly a whole new group of diseases will cause valvular disease compared to the aortic valve. So any myocardial disease will cause mitral regurgitation. So this is what I was talking about earlier on, the splitting up the mitral valve leaflets, not just the anterior and posterior, but into P1, P2, P3, separated by these little folds that you can just see represented in this diagram. People talk about the surgeon's view and the sonographer's view. They're upside down from each other because the surgeon, when he opens the heart, he opens the atrium and looks at it from the atrium, and the sonographer's echo view tends to look at it from the ventricle. I don't worry too much about that. What I would worry about is simply these images, so because these are the echo images, and something really fortuitous happens when you start to label in transthoracic echo, when you start to label which one's which. Nobody will remember Dusty Bin. There was a program, it must have been in the 1980s, that featured Dusty Bin. I can't even remember the Ted Rogers and Dusty Bin. I can't remember the name of it. Anyway, his thing was 3, 2, 1, like that. And that's all you need to remember is Dusty Bin's 3, 2, 1. Because whenever you start to label the scallops in transthoracic echo, it's always 3, 2, 1, or almost always 3, 2, 1. So clearly this is the anterior leaflet. Clearly this is the posterior leaflet. It just goes 3, 2, 1. You just need to remember that, 3, 2, 1. Two-chamber view. The two-chamber view is a funny old thing. Because if you look at it carefully, what you see is it looks like there's 3 parts to the mitral valve leaflets, and that's because you cut across the commissures twice, because it's a smiley shaped thing, and a straight line cuts across it twice. So when you've got the here, you see a bit of posterior leaflet here, a bit of posterior leaflet here, a bit of anterior leaflet floating in the middle. But in terms of scallops, once you've identified leaflets, it's still the same thing, 3, 2, 1. The short axis, 3, 2, 1. And the only thing you need to remember is in the standard long axis view, standard parasternal long axis view, it's A2 and P2, you see. So you see the 2s, if you like. But everything else is 3, 2, 1. So actually, although it makes it sounds like it will make it more complex, it's actually, if you just want to remember it for the purposes of the exam, which is probably all you have to do, because honestly, you rarely talk about this in transthoracic echo in clinical practice. You do it all the time in transesophageal echo, but not in transthoracic echo. If you just want to remember, it's really easy. Identify the leaflet and then just 3, 2, 1 across the screen. Okay. Carpentier classification. It's just about what goes wrong with the valve, and it's a bit of a surgical thing, but actually it's quite a helpful thing. The valve leaflets, so you look at them, you see that sometimes you look at them, you'll see they're leaking, and it'll be obvious why they're leaking. And sometimes you look at them and you'll not be sure why they're leaking. So I think, I think the most helpful way to think about this is a modification of this surgical thing, which is called the Carpentier classification. So the first thing I do is look at the leaflets. Do the leaflets look normal or thickened? If they're thickened, where are they thickened? If they're thickened, are they calcified? So the first thing I do if I'm not sure what's causing the mitral regurgitation is I go through the structure of the leaflets. And the second thing I then do is I then do this Carpentier thing and look at the movement of the leaflets. Is the movement of the leaflets normal? Is the movement of the leaflets excessive? And if the movement of the leaflets is excessive, does that mean there's prolapse? Does one go too far back? That's usually what it means if the movement is excessive. Or is the movement not enough? And if the movement is not enough, does it not open sufficiently? In which case it's usually rheumatic. Or is it unable to, is the problem it doesn't move enough to close sufficiently rather than open, in which case it's usually something to do with the myocardium, so it's usually functional. So I do that. And then the last thing I do is look at the direction of the mitral agitation. And if you put those three things together, the structure of the leaflets, the movement of the leaflets, the direction of the mitral agitation, it almost always will tell you what's likely to be the cause of the mitral agitation. So that's the way to go through it. I particularly mentioned, I'm not really using the Carpentier classification, but a modification of it. But I particularly mention that because, again, that is mentioned in the syllabus itself. So here's an example. So look at the leaflets. The leaflets look normal thickness. They're not thickened. They're not calcified. So the leaflets look normal. The motion of the leaflets is not normal. They open, but they don't move enough to close properly, because instead of coming down and closing, they're doing this. They're stopping here, aren't they? Like that. So there's a restriction of movement in closure. And you'll see, I think in the next slide, maybe not. The next again slide. So the same thing here. I can't remember if it's the same patient, but leaflets look normal, but they don't come back and close properly. They can't come further back than there because the cords have gone tight. So it's that triangle shape underneath the valve because it's not closed properly. There's restriction and closure, and usually the jet of mitral agitation is a central jet that you see here, just like that. So this is not caused by a problem with the valve in this case. This is caused by a problem with the myocardium. You can see it's big and poorly functioning. So this is mitral agitation caused not by the valve, but caused by the ventricle. And that's often referred to as functional mitral agitation. It's not caused by the valve pathology, but it's caused by the ventricular pathology. So functional mitral agitation. So here's a different example. You look at this mitral valve, the valve looks thickened. It does not look calcified. The thickening may or may not be just, you don't see it quite clear enough here, be sure if it's the whole leaflet or just the tips, but it doesn't look calcified. Its movement is not restricted. Its movement is excessive because it comes back into the atrium. So you can see there's mitral agitation, a thickened valve, which looks like there's too much tissue in, that is more mobile than it should be. That's a degenerative valve with myxomatous valve disease. So typical appearance of a myxomatous valve with mitral agitation. You see the same thing here, thickened valve leaflets, too much movement, and some prolapse. Here's an example of a rheumatic valve. Essentially what you're seeing is the valve isn't doing anything, and it's just the extremities of the leaflets that are going backwards and forwards like that, and you get both mitral stenosis. You can see the turbulent forward flow and mitral agitation. The direction of the mitral agitation just depends on the orientation of the valve, so it isn't very helpful in the case of rheumatic disease like this. So as first stage is looking at it, going through that schematic discussion to decide why there is mitral agitation. Once you decide there is mitral agitation, you decide how bad is the mitral agitation. And my goodness, that's the crux of the matter. It's really tough to do. You need to measure lots of things, put them together, use your experience, and come to a conclusion. It is easy if the mitral agitation is mild. It is easy if the mitral agitation is very severe. But the bit in the middle, deciding is this, moderate or severe, is this mild or moderate, that bit is really tough and important for the patient, of course. So area of the jet, you can compare to the area of the left atrium. These are the things you can measure. PISA, we've talked about, and we've gone through that earlier, where you need to measure the acceleration here into the hole in the valve. So you measure the acceleration and you measure the flow through it. The vena contracta is the narrowest width of the jet after it goes through. Regurgitant volume, I really don't think you'll be asked to measure regurgitant volume. It's too complex a calculation for the exam. So you need to know the values for it. I guess you might be asked those, but I don't think you'll be asked to do the calculation. This is an important, it's like a place actually, it's supposed to be about before. This is an important thing, that if you've got functional mitral regurgitation, so mitral regurgitation because of myocardial disease, and that myocardial disease is ischemic heart disease, then people do particularly badly, presumably because they've got two serious heart diseases. So the outcome from moderate ischemic mitral regurgitation is roughly the same as the outcome for severe mitral regurgitation of any other cause. So that in general, you've got a lower threshold for treating people who've got mitral regurgitation because of ischemic disease than if they've got mitral regurgitation for another reason. Who do well with mitral valve repair surgery? Well, young people, we've got less wrong with them, we've got less bad valves, of course. But in general, that's a slightly facetious comment, and surgeons don't mean it like that. But in general, those people, and if it's the posterior leaflet, it's better to repair than the anterior leaflet. If it's in the middle of the leaflet, it's better to repair than the sides of the leaflet. And the more extensive the abnormality in terms of the involvement of the leaflet, the harder it is to repair. And while there's lots and lots of things you can measure, these are the things that the BSc particularly have listed, so are likely to come up in the context of the exam, and they're on the handout sheet. And finally, stress echo has definitely got a role to play in moderate mitral regurgitation, particularly in primary heart valve disease. What you're really looking for is changes in the amount of mitral regurgitation, worsening of the mitral regurgitation. You want you want to see, the question you're asking is, does the mitral regurgitation get worse when you exercise somebody, which maybe, well, it looks at rest like moderate, once you start to exercise, it gets worse. So does the mitral regurgitation look worse, or as in with mitral stenosis, does the pulmonary artery pressure go up? And an additional important thing is, because of the strain that mitral regurgitation puts on the ventricle, if the ventricle doesn't improve in function when you make somebody exercise, then that's a really bad prognostic sign. So you want to see that there's some contractile reserve in the ventricle as well as change, as because that's got a bearing on the likelihood of surviving the operation, whereas other things determine whether or not an operation, if successful, is likely to help your symptoms.